It's been a year on indeed, and we've been joined via Zoom for a review of Ghana's response to this pandemic in the past 1 year by the Director of Public Health at the Ghana Health Service, Dr. Frank Esiedu-Bekwai. Dr. Esiedu-Bekwai, thanks for joining us.
Thank you very much.
So, take us back to the 12th of March 2020. Just the day before that, the World Health Organization had declared that coronavirus was a global pandemic. Did you expect that we'll be seeing a case in Ghana in less than 24 hours?
Yes, thank you very much. Let me say that it was coming. I mean, Nigeria had reported their first cases, and then Kovacs had reported. And I remember the media at that time were asking, why are we not reporting? Are we hiding? We said, no, we were actually looking for it. We had done at that time about 50 tests, and they were all negative. So if you look at the global world now, and there's a lot of trouble, we were not surprised that we had our first cases. But clearly, the way the disease spread, it was likely going to be an imported case. And let me say that we have a good testing facility in the country at that time, which was the Buchi and then KCCR. So we were just anticipating that a case will be coming to Ghana. Our focus was that you are not likely to prevent corona from entering your country. What we're focusing on is how early to detect it. And that was our focus. So we are not surprised that we had the first cases in the country.
The cases started coming in ones and twos, and then we saw an explosion in terms of numbers in Ghana. All the same, we've still been touted as one of the countries with the effective response. What would you say was our strategy, Dr. Esiedu-Bekwai, from the very beginning in dealing with COVID?
Yeah, so let me say that before even COVID entered the country, we had really started going back. We were anticipating an outbreak of meningitis. So we have our rapid response team that was going around in the northern parts of the country to see how prepared we were. And following Ebola, we had a national preparedness plan for public health emergencies. So and that plan actually tried to address situations along thematic areas. So we have an area of coordination, an area of port of entry, surveillance, then you even have the general surveillance, you have the laboratory, then you have the case management, you have risk communication. So in terms of preparedness, that's what we were looking at this. So for coordination, at the national level, we have our National Technical Coordination Committee, then we have our EOC, and then if you look at the regions, they have the Emergency Management Committee. So all these structures exist. So it's not COVID that brought about these coordination structures. Then we had our lab. Luckily, we have the Buchi, which is a very reputable lab, and we had KCCR. So we have our surveillance. So we have a setup in the country that was ready to address COVID. And let me say that when we had the COVID, we actually heightened our response. So we realized that in terms of the structure itself, it more became very, very high level, very central. So we have the National Technical Coordination Task Force, which is actually chaired by the president and co-chaired by the vice president. And that leadership is so crucial because in terms of addressing an enormous situation like COVID, you need support, financial support. And that's how we situated our response. And then we came out with clear strategic objectives. One was to limit and minimize importation. Because clearly, the disease does not exist in the country. It has to come from outside. So the first objective is that limit importation. In that case, that means you need to strengthen your port of entries. So that's why in the early stages, I mean, a lot of people were talking about how prepared are we at our airport. But we said, looking at the incubation period of COVID, you are not likely to catch it at the airport. You may be having somebody incubating, you may enter the country, so you may rather get within the country rather than the airport. But we try to strengthen our airport. Then you look at second objective was how are we going to detect the cases. So that's about your surveillance system that you need to have. Then you need to have to slow down the spread, and that's how we need to do things like contact tracing, and then the risk communication, and then you have to see managing the care of the disease or the sick. So those were structures that were put in place. We had an objective that means providing the local enterprise to support COVID. So that's why we have to now see local entities providing their own PPE. So it was a very holistic plan that we had in place.
Now, Dr. Sedibekwe, what would you say happened from August, September, October, December, where we saw that at a point we were actually doing our most tests in the country at the airport? And it was at the airports that we were doing the highest number of tests. The case count looked low, but at the same time, WACBIP did a study to see that about 1 million people in the Greater Accra region alone had tested positive for COVID antibodies. It looked then like the coordinated response that started in March had taken a nosedive.
No, you see, I think that, let me put some clarity here. Normally, when you are managing, let's say, a pandemic, what you are managing is you are managing a disease. You see, for COVID, you are looking at two things. You are looking at disease and infection. So if you look at our dashboard, now we have over 80,000. That 80,000 people, they are not all of them are sick. There are people who have been infected. So let me say, if you say you have an outbreak of meningitis, there are people who have the disease. They have been infected and they have come out with symptoms that you say, based on it, they have meningitis. For COVID, we are looking at two things. If people have been infected, they are not showing disease. They are not showing symptoms. So what WACBIP did, they tried to find out how many Ghanaians have been exposed. You understand? So, and that one is an extrapolation. It's a sample, so it is not in real sense the number of Ghanaians that have been infected at that time. Our dashboard is clearly mainly talking about people who have been infected and also disease.
But it's still an empirical figure to go by, isn't it? Even though it's an extrapolation, I understand that totally, but it's still an empirical measure of the rate of infection. And these were people who potentially would carry and spread the disease, is it not, if they had antibodies in their system?
What I'm saying is that you cannot compare the two set of data, because one is like a survey that you're extrapolating, and one is real-time testing. So, I mean, and let me be clear, for Ghana Health Service, our intervention was not dependent on the number of cases. Our intervention has remained the same, adherence to the protocols. I mean, so it doesn't matter whether you have 1 case or 10,000 cases or 1 million cases. That's never the issue. And I'm sure we have never changed our stance about our interventions. So what we were just demonstrating that there's level of infection, which to us was normal. So let me say that if you look at the trajectory of the response over the period, it relatively start very low and it got to a high level somewhere in June, July. And that rise sinks with what is happening or what happened across Africa. So if you look at the trajectory of a pandemic across Africa, what is happening like now, which is supposed to be a second wave or the first wave, sinks with most of what is happening across Africa. And then we, along the point in time, realized that people were not getting sick. You see, you cannot hide COVID. When COVID becomes very pronounced, a lot more people will become ill, a lot more people will be dying. If you look at the data from, let's say, September, October, November, we closed down our isolation centers, we closed down our treatment centers. Nobody was getting ill. It was infection. So what is happening is that at the later part of December, remember we had this new variant, then you have a new kind of dimension of the infection, severe disease and death. So for us, it has been a good run. Let me run you through some of the things that has happened. For, let's say, for the port of entry, before COVID, we were actually running more of a manual system. But because of COVID, we have more of electronic data collection at our point of entries. We have more booths, all to ensure that we have more space so that we ease congestion and promote physical distancing. We even have an in-house testing facility. I mean, this is one of the best things that can happen. It helps the system. It also gives convenience to the passenger. By mean that one, we are able to detect over 1,200 cases at the airport. So that's at the point of entry per state. If you look at the general surveillance, Ghana used to run more of a manual kind of data collection. So we tried to pilot an electronic system. When COVID came, we ran a nationwide electronic system, which is called the SORMAS. So Ghana is one of the few countries that is running a nationwide electronic data transmission. If you look at the labs, we were having just 2 labs. Now, as I speak, we have over 30 labs. A visible number of them are private. So clearly, our capacity has actually improved over the period.
Right.
So there's a classes that has come because of COVID. We are not there yet, but I think that a lot has been gained over the period.
I can imagine that, Dr. Seribekwe. Finally, where we are now is that we are in the middle of the first phase of vaccinations. For those out there who may be concerned that the distribution of the vaccines is not as equitable as preferred, I know that there were some doctors on social media, for instance, who were expressing concern that they had not been vaccinated, and we had persons like myself, public figures and celebrities who are being vaccinated in public to sort of raise awareness. Have these issues been addressed, Dr. Seribekwe?
Yeah, so apparently, in trying to address the limited vaccines, we looked at the segmentation. So that's geographic, and then you look at population-wise. And then we also need to address vaccine hesitancy. So we carefully selected who to get the vaccines. So that's why we are looking at 2 main issues. Who is more likely to get a disease, who is more likely to die. So most people to get a disease are health workers. So that's our first segmented group. Then you're looking at people who have underlying conditions, who are 60s and above, they are more likely to die. So that's also a very segmented population you need to focus on. But then you need to address vaccine hesitancy. So you need to have influencers. So that's why we now have to bring on board people like some prominent chiefs and religious leaders, and then some media personnel. But if you look at in actual terms, the numbers that have been vaccinated are still fitting the 3 key populations that we focus on: health workers, people with underlying conditions, and then the people who are 60 years and above. But let me say that with our new vaccines that we've gotten, we are moving beyond the geography to focus on the health workers. So that a week ago, our DG asked for the list of all health workers in the regions, and that's what we're going to do. So the next few days or week, we are going to make sure that all the health workers in the regions, outside the Greater Accra and Ashanti and Central, are going to be vaccinated, so that we get a very immunized workforce.
Been advisable to look at some of the other hotspots like the Western region, where we had a lot of concern come from, and try and get those health workers to quickly be vaccinated, even alongside the current number of public figures and prominent personalities who are also being vaccinated.
Yeah, so I'm saying that the health workers all over the country are going to be vaccinated. So it's not just going to the Western region. In terms of geography, Western region is going to the next. But for health workers, it's going to be across the whole country, because we are saying that health workers must be protected so that they can actually offer the kind of services that we are looking for. So, I think that a few days ago, the DG asked all regional directors to bring the list and the numbers of health workers, and that is being done. So we have a consignment of the AstraZeneca, which is purely going to health workers to ensure that we have the needed immunity among health workers.
Is this consignment already in the country? Is it part of the initial 600,000, or it's part of the next batch of vaccines?
No, not the next batch. We already have it. We have it all. Aside the 600,000, we had some consignment from the Indian government, and then another donation from another entity. So there's a portion of the AstraZeneca and Sputnik, which is in the country. And we are going to use it. And let me say that 7,000, we even have a buffer. So we're going to use all of that to ensure that the health workers are vaccinated.
Pardon me, Doc. Did I hear you say that there's a consignment of Sputnik vaccines that are already in the country?
Yes, I think we had it's about 10,000 or 15,000. If you look at Ghana now, we have actually registered 2 vaccines. So that's the AstraZeneca and the Sputnik. So far as they have been registered and they are safe for use, when we get the right kind of numbers, we'll make sure that they are put to use. But for now, we have a reasonable number of AstraZeneca which we are going to use for the health workers.
When did the Sputnik vaccines arrive and how were they procured? Were they donations or we bought them?
They are more of I was saying they are more of donations that has come. You see, if you look at our strategy, we are looking at multilaterals and then bilateral entities. So like the AstraZeneca was given to us by the Indian government. And then I think the Sputnik, I think the UAE, I'm not very sure the percent, but okay. The idea is that they want to make sure that we have the right number of vaccines. So we have a limited number of the Sputnik in the country. But, to add to it, we have a reasonable number of the AstraZeneca to suffice the health workers.
Right. I was speaking to Dr. Nsiah-Sarwey earlier today, and he was confident that the next batch of Kovacs vaccines, which of course are AstraZeneca as far as we know, would arrive in the country next week. Are you able to tell us how many of the doses are coming next week?
Next week, you know, originally this 7,000 was supposed to come in March, but it ended up coming in February. So what is happening is that the Kovacs facility says that they are going to get us about 2 million doses from now to the next few weeks. It's not very certain the date, for the date tends to vary. What they are trying to say is that they are trying to cover most of the countries under the package. So when they cover it, then they go to the next phase. So I'm not certain whether it will be next week or next 2 weeks, but what is clear is that they're going to get a larger number of vaccines going forward.
Dr. Franklin Desiedu-Bekwai, thank you very much for joining us this morning. And I must say that we are very grateful to and very appreciative of the great work that is being done by the Ghana Health Service and all the authorities and all the leadership. As much as we hold leadership accountable and we try and get to the bottom of issues, we really appreciate the work that you do to keep Ghanaians safe, sir.